Hi, this is Mark Bramer, founding member of iCare Analytics. This video is the first of 2 sessions to introduce you to a unique tool used for patient population risk management activities. This session is intended to explain how the CARE Probability of Disease engine works, followed by a second session that will attempt to highlight some meaningful ways to use CARE's predictive results in administrative and financial healthcare settings. Before I introduce the inventor of the CARE engine, I would like to present my background and role. I spent some 30 years helping implement predictive risk analytics in the capital markets with Moody's Analytics. The risk management work helped me appreciate the value that this CARE technology brings to risk management practices in the healthcare sector. In the fall of 2013, I worked closely with the University of Notre Dame to secure the technology transfer of the CARE PD engine and spent the following year interviewing many of the top hospitals and clinics about the use of disease prediction tools in clinical and financial settings. Nitesh Chawla from Notre Dame, a well-respected data scientist in the academic and healthcare community, is the inventor of the CARE PD engine. His prior banking experience in the use of predictive analytics helped inform and guide the direction that he took regarding disease prediction in healthcare settings. We are pleased to have Nitesh continue to serve our firm as scientific advisor. The need that animated Nitesh to create the CARE PD engine is a common need across all people, and therefore across all healthcare payers and providers. What are the potential disease risks of each and every patient under care? A colleague at Harvard offered to collaborate with Nitesh because he had access to a huge source of patient claims data at Harvard. And so this joint effort created the perfect research opportunity to address this need quantitatively. The awarding of a patent for CARE was further indication that this project had potential commercial value and thus triggered the transfer of the commercialization rights to our firm. One thing Nitesh and I acknowledged from our prior work is that any modern risk management practice needs to adopt and utilize a universally accepted and understood measurement of risk, a probability of a future risk event, not a proprietary internal patient score or some classification of low, medium, or high health risk, but a quantitative probability, like 88%, which means the same to anyone and everyone. Like in this example, an 88% likelihood that a patient will develop hypertension, not otherwise specified, in the future. This probability estimate can be produced by the CARE PD engine for any patient or patient population using medical histories of diagnoses recorded in claims data under care plans with Medicare, Medicaid, and private carriers. Let me take a few minutes to stress the importance of the need for 2 distinct assessments of health risk, so fundamental to proper risk management practices. The first involves a current profile of health risk for each patient evidenced by their diagnosed medical conditions. This is commonly described as episodes of illness, which have prescribed services associated with their diagnosis, management, and treatment. There is a business need to systematize this process of recording, grouping, and monitoring these episode of care groups so that performance measurement can be undertaken to address demand and track financial performance and trends. This is accomplished by a coding system. One can think of Optum's Symmetry platform that helps a hospital construct and systematize this process. The overall assessment of health risk for a patient under this episode of illness and treatment process is in fact a scoring system intended to reflect the current state of a patient's health risk. This forms the risk stratification metric for a patient population. This care management process requires a lot of effort and investment to structure and implement, but it only addresses half of the risk assessment and measurement scenario. Hospitals need to manage the health risk it already has, but equally important is the information needed to help them manage future health risk that will materialize going forward. Both scenarios have huge financial impacts. To address the latter, a forward-looking assessment of health risk is absolutely critical. This can be supported by substituting existing diagnosis with predicted at-risk medical conditions that a patient is likely to develop in the future. This allows the care provider to estimate future demand and thus future revenue and costs associated with predicted episodes of illnesses and their treatment. CARE's probabilities that a patient will develop disease conditions is an absolute measure of risk on a scale of 1 to 100, a mathematical probability. And the data needed to produce these probabilities exist in the structured claims data that has been organized and managed by a handful of claims vendors for decades. This claims data, in effect, is the system of record for millions of episodes of illness histories that form the current scores today. This sets up a scenario that involves minimal effort to launch an evaluation of care results on any patient population. The data that CARE needs exists in a format that can easily be imported into the CARE engine for processing. Internal scores in clinical settings are proprietary by their very nature. A score developed and used at the Mayo Clinic is not the same one used at the Cleveland Clinic or any other hospital network. Probabilities of future diseases and disease progressions for a patient or patient population are the same at Mayo or at the Cleveland Clinic. It might be useful to highlight one more distinction between scores and CARE's disease predictions and progressions. CARE uses big data sets to make predictions, using a multi-year history of thousands or even millions of patient lives with multiple patient visits that record multiple diagnoses. With CARE, it is straightforward to measure predictive power from such a patient universe. We can backtest for every patient, starting with their first visit and diagnosis, and walk forward, capturing each CARE prediction for each patient, to then compare these predictions to actual outcomes. Clinical health scores were never designed to include at-risk future conditions. These scores typically reflect conditions within the past 12 months. It is impossible to backtest a non-predictive score. One can track a trajectory of scores over time if such scores and their changes are archived for this purpose. But testing for predictive power won't be possible. Certainly there's a strong use case to combine the value of both scores and predictions in the medical records of patients under care. I want to now use the next two slides to put into context the CARE process. In the third slide, we can talk about the validation exercise once CARE's PDs are produced from any provider's patient population data set. Let me offer an analogy to a well-known big data business process that works in a similar way to CARE. Netflix or Amazon knows that I'm a user of their stuff over the years, that I'm a 62-year-old male living in South Bend, Indiana. They can sequentially track my multiple decisions for their books and movies directly from their order entry systems. They know the same about millions of other people who have similar demographics to me and patterns for their own favorite books and movies. They can profile and rank order what I am most likely to enjoy as my next few books or movies and present this listing to me at any time on demand. The CARE technology and algorithms do something similar. So let's take a look. CARE looks at every existing disease for an individual. So here's patient 91409 with hypertension and diabetes. For each of these diseases, CARE then creates a grouping of patients from the entire patient population universe that have the same two diseases in common. CARE then uses similarity statistics within each group to establish the connectedness of individuals based on their historic medical diagnoses. CARE then applies collaborative filtering using inverse frequency and vector similarity to produce the patient's disease predictions based on similar patients within each group. Lastly, CARE aggregates and sorts all predictions across all groupings to produce a rank-ordered patient risk profile. Let's make one more run through the CARE process with an example from the Harvard data set. This is exactly what we would do with any patient data set with a potential user. Once we do this, then we can backtest in a walk-forward manner the CARE predictions and recorded outcomes for each and every patient to estimate predictive power. I'll cover this in the next slide. This example highlights the visits, diagnoses, and CARE predictions after each of 3 visits of a cancer patient. In the first visit, the patient is diagnosed with cancer of the esophagus. CARE makes its run through the data universe and determines the likely at-risk conditions for the patient to progress to bronchus cancer, anemia, and then secondary cancer of lymph nodes and liver. And the list goes on, as you can see. In the second visit, the same patient is now diagnosed with liver cancer, and CARE repeats the process to then predict a different rank-ordered list by probabilities, continuing with bronchus, anemia, urinary tract infection, and cancer of the lymph nodes, and so forth. And the third visit shows a record of conditions that were in fact predicted by CARE in the top 5 rank order based on earlier diagnoses, indicating good coverage predictive power and good rank order predictive power. Now let's discuss predictive power or validation. To measure predictive power, we need to define what we are measuring. If you're a banker, you only care about a loan defaulting, and then if it defaults, how much you can lose. The credit risk you want to measure then is an outcome that either the loan is performing as agreed or it is in default and I could lose money. Kind of like a projected either or, yes, no. In a healthcare setting, we are interested in multiple disease outcomes. So we are interested in predictive coverage. How well does CARE predict one or more future medical conditions of a patient and thus the entire population? And how well does CARE rank order these predictions as accurately as possible? To measure improvement performance, we then compare CARE's predictions to a baseline, generalized statistics for disease prevalence that exist in the general population over time. There are 2 performance measures that have value to disease prediction. One is the ability to accurately predict at-risk conditions that actually are then diagnosed for a patient. This is the coverage metric. The other is how well does the rank order of disease predictions place the most likely conditions towards the top of the list when compared to actual patient outcomes. What we found with the original data set from Harvard was that an improvement of just over 50% existed when CARE's predictions were compared to a baseline of disease prevalence in the general population. The reason that there's a range of 41.2 to 54.7% is that multiple tests were run to establish predictive power. This is all documented in the CARE white paper if you want a copy.